Deepak, Deepak,
Yeah.
can we start?
Yeah. Yes.
Dr. Prashanti, can you just mute your mic for 1 minute? I just see checking if there's an echo coming out of your mic.
Okay.
Just 1 minute. No, it's not from your mic. You can open it up. Somewhere there's a humming noise.
One second.
Now that is better. Deepak, we should start, Deepak.
Good morning. Learning gives creativity. Creativity leads to thinking. Thinking provides knowledge, and knowledge makes you great. With this famous quote by Dr. APJ Abdul Kalam sir, it is my pleasure to welcome all our delegates for this webinar on this lovely day. A very good morning to one and all. On behalf of the Department of Orthodontics, SRM Katangalathu Dental College and Hospital, I, Dr. Kritika, take the honor in welcoming our speaker for the session, Dr. Prashanti Bollu ma'am. We now have the welcome address for the session by Dr. C. Deepak sir, our head of the Department of Orthodontics and the immediate past secretary of the Indian Orthodontic Society. Over to you, sir.
Yeah. Good morning, everybody. And on behalf of the Department of Orthodontics and Dental-Facial Orthopedics, SRM Katangalathu Dental College and Hospital, I welcome to a wonderful webinar by Dr. Prashanti Bollu. She is the program director of orthodontics from Roseman University, USA. She is, very warmly consented to this webinar. She'll be speaking on the Cbct in orthodontics, which is going to be very useful to all of us to listen to this. And she has given time very graciously to this webinar and to all of us. And I also warmly welcome participants from over 36 countries who have registered for this webinar. And that goes to show how much Dr. Prashanti's lecture is valued. And we're all looking forward to gaining a lot of information and knowledge from this webinar. Thank you so much, Dr. Prashanti. Thank you so much, all the participants and attendees for attending this webinar. Thank you so much.
We would now be starting the session by lighting the auspicious lamp. By our esteemed speaker, Dr. Prashanti Bollu ma'am. Our Dean, Dr. Deepak sir. Our HOD, Dr. Deepak sir. Our Dean, Dr. Vivek sir. Our Vice Principal, Dr. KT Magesh sir. And the Dean of SRM Ramapuram Dental College, Dr. Ravi sir. Thank you. We now have the invocation song to invoke the blessings of the Almighty. Maitrim bhajat akila hrijitrim, Maitrim bhajat akila hrijitrim, Maitrim bhajat akila hrijitrim, Atmavativat paranapi pashyat, Atmavativat paranapi pashyat, Yuddham tyajat spardham tyajat, Yuddham tyajat spardham tyajat, Tyajat pareshvakramakramanam, Tyajat pareshvakramakramanam, Maitrim भजत अखिलहृजेत्रीं मैत्रीं भजत अखिलहृजेत्रीं जननी पृथ्वी कामधुघास्ते जननी पृथ्वी कामधुघास्ते जनको देवः सकलदयालुः जनको देवः सकलदयालुः धाम्यतडट्ट धयत्वं जनतः धाम्यतडट्ट धयत्वं जनतः श्रेयो भूयात् सकलजनानां श्रेयो भूयात् सकलजनानां श्रेयो भूयात् सकलजनानां श्रेयो भूयात् सकलजनानां श्रेयो भूयात् सकलजनानां. Thank you. Over to our Dean and Head of the Department of Oral and Maxillofacial Surgery, SRM Katangalathu Dental College and Hospital, Dr. N. Vivek sir, for the inaugural speech.
Good morning, one and all. It gives me immense pleasure on behalf of SRM Katangalathu Dental College to welcome all of you for this webinar organized by the Department of Orthodontics, SRM Katangalathu Dental College. I take this honor to welcome Dr. Prashanti from the US for taking her time and adjusting to our time schedule to be part of this webinar and to give us a wonderful lecture on the reality and what is essential today and the essence of CBCT, the use of CBCT in orthodontics. And also I gather she's also qualified in finance. She's also qualified in hospital management. So a lot of extra qualifications, and I'm sure her lecture will be of immense use to people who are here, and she will be happy to probably answer questions and discussion followed by her lecture. Welcome to you, Dr. Prashanti. I also welcome Dr. Ravi, Dean of SRM Dental College, who also heads the Department of Orthodontics at SRM Dental, our sister concern, part of the same university. And I welcome you, sir, and I'm very happy that you are part of this webinar too, in spite of your busy schedule as well today.
Thank you.
And I welcome all the faculty and all the delegates for this program. And at this juncture, I'd like to compliment Dr. Deepak and his team for putting up a show like this and inviting participants across the world and enlightening the future students on the current scenario with CBCT. Without much time, and I don't want to waste, because I think people are waiting to listen to Dr. Prashanti, but let's all hope that we have a wonderful 2021. Let's hope this pandemic and issues that we have gone through in 2020 be better for us, and all of you stay safe, and wishing you an advance Happy New Year. Thank you.
Thank you, sir. We now have a special address for this session by our Vice Principal and HOD of the Department of Oral Pathology, Dr. K.T. Magesh, sir, and Dean, HOD, Department of Orthodontics of SRM Ramapuram Dental College, Dr. Ravi, sir.
Ravi, sir.
Yeah. Good morning. The speaker of the day, Dr. Prashanti, Dr. Vivek, Dean, SRM Dental College, Katangalathu, Dr. Deepak, Dr. Magesh, Vice Principal, staff, and my dear students. A very good morning to you all. It's a pleasure to be a part of this webinar on CBCT. CBCT scan gave orthodontists a complete picture of patients' hard and soft tissue in 3 dimensions. Though the accuracy and reliability of CBCT images have been evaluated and found adequate for planning of implant placement, bone level assessment in periodontal disease, or in assessment of oral tumors and lesions, I would say it has been always underutilized as an orthodontic and orthodontic diagnostic tool. The problem being the limited evidence on the accuracy and the reliability of using 3D images and measurements in craniofacial analysis. If understood properly, CBCT can be effectively used in assessment of simple craniofacial problems like facial asymmetries, functional shifts, canted occlusal planes to complex craniofacial syndromes, where 2D methods like lateral and PA cephalograms have huge limitations. I think with these few words, I'm looking forward to your lecture, Dr. Prashant. Thank you very much.
Our HOD, Dr. Deepak sir, and our Dean, Dr. N. Vivek sir, would be the moderators for this lecture. I would now like to call upon Dr. Deepak sir, our HOD, to introduce the speaker for our session.
Yeah. Thank you, Dr. Kritika. It's a pleasure to welcome Dr. Prashanthi to our webinar. And Dr. Prashanthi received her graduation from the Boston University School of Medicine with a DMD degree, and she's also very proudly say that she's a dentist from India. She's graduated from the Government Dental College, Hyderabad, and then she moved on to the Roseman University, where she completed her advanced education in orthodontics and also a Master of Business Administration. Now she's a program director of orthodontics there. She has done extensive work on CBCT as well as practice management tools, and she takes lectures around the world. She also trains her alumni on how to manage the practice very effectively, which is the latest thing. And we have to all learn that it's not just managing, practicing orthodontics and dentistry, but also managing our practice very effectively. So I request Dr. Prashanthi to please start her lecture, and because I'm sure everybody is waiting to listen to her today. Dr. Prashanthi.
Thank you. I'm quickly browsing through the participant list, given that people are attending from various countries. First, I'd like to say good morning, good afternoon, good evening, whatever works based on your time zone. This is a true honor for me to be here today. And I'd like to first thank Dr. Vivek, the Dean, for giving me this opportunity. And Dr. Ravi, thank you for those wonderful words. I think you've actually stole the thunder of the overall topic. You've done fantastic introduction of the CBCT. I don't think I can do any better than that, but I'll try my best to make it as informative as possible. I do thanks to Dr. Magesh and Dr. Ravi as well. And finally, a big thank you to Dr. Deepak for organizing this and for being persistent and patient with me. And lastly, I also want to acknowledge Dr. Kritika. Oh my, she has a beautiful voice. And thank you for the kind introduction overall, everyone. So with that, let me get started. 1 second, please. Dr. Deepak, could you please verify that you can see my slides?
Yeah, you're visible.
Yeah, we can see your slides.
Fantastic.
Yeah.
I request everyone to please mute your...
Yes, we will do that. We'll mute it and also stop the video so that the screen doesn't.
Fantastic. So the objective of today's session is to review the evidence and some of my personal experiences working with CBCT data when it comes to the accuracy and reliability of using CBCT, especially in orthodontic diagnosis and treatment planning. Once again, I am Dr. Prashanthi Bulu. I am the program director of the AEODO residency program. That's an interesting name if you wonder. That stands for Advanced Education in Orthodontics and Dentofacial Orthopedics. It's one of the largest residency programs in the nation with about 10 residents per class, and it's a 35-month program with a combined MBA program. if, in case you're wondering where I'm from, who wouldn't want to live in a beautiful city like this? This is Las Vegas, which I call my new home. I was born and raised in Visakhapatnam, Andhra Pradesh. And my initial dental school training was from GDCH, Hyderabad. About 20 years ago, I came here, but the roots are something that I'm ever so grateful for, especially for my initial foundation in dental education back in India. Now, when I first came here, I was truly intrigued by the healthcare system in the United States. And in India and many other countries, primarily depending upon fee-for-service systems, among other systems, the US having a third-party payment system, that really intrigued me. And I really wanted to learn more about how that works. And that's what got me into a master's in healthcare administration. And it was a truly life-changing experience for me. The overall graduate education system itself, the learning systems, as well as the healthcare systems being so unique, it gave me a very good taste of, the third-party payment system. So from there on, I moved on to Boston University. I lived in Boston for many years, and I worked there as an employee in various administrative capacities, and completed my DMD degree from BU. And right after, I moved to Henderson, Nevada. Most people would come to Vegas for the first time to visit, but the first time I ever came to Vegas was for the interview to become an orthodontist, and I just fell in love with the city and never looked back. So this is what I call my new home. Now, I also completed my master's in business administration. That actually intrigued me as far as the program here that really blends the training with the orthodontic certificate, but as well as, integrates the business concepts as well. I furthered that with some more professional advancement courses, which I continue to do primarily in outcomes research and healthcare management, and primarily from Harvard and a few other institutions whenever I get a chance. Something that I really enjoy is outcomes research. So as far as my professional journey, I've been very, very fortunate to work in various capacities as an administrative assistant, as a research scholar. And then soon after graduation from the orthodontics program, I was hired as a clinical and research faculty. So I took that as a part-time position and started working outside in private practice as well. And then a few years later, as I continued on my research path, I was promoted as a head of research for the College of Dental Medicine and eventually as the IRB chair. And that's another area of particular expertise that I hold when it comes to institutional review board aspects related specifically to research conduct. So that's something I held for a few years for the university, for the Roseman University with its 9 colleges, including pharmacy, nursing, and dental, before I became the program director here. So I'm a board certified orthodontist, and I practice here in addition to my clinical and research faculty position. What I really enjoy is also being actively involved in private practice. I think it helps our academicians to have, the real world perspective, especially when we're teaching residents that are actually moving into the next generation of orthodontics. A lot of what I learned, for example, taking impressions, we no longer even take any impressions. We do intraoral scanning. So as the systems are changing, as the technologies are advancing, I think it helps for us to be in sync with the real world scenario. So that's a little bit about me. And now, as far as our university, Roseman University is actually fairly young. It's a private not-for-profit institution that has grown tremendously in the last 20 years. It was founded in 1999, and in 20 years, it's one of the largest institutions in this area. And it continues to grow at an exponential pace. And that's definitely due to the progressive leadership that we have. And that's what actually grounds me here in Henderson more than anything else. Now, I often get the question, where is Henderson? How far it is from Las Vegas? And so to give you a perspective, top right, that's the Strip. So we're only about 5 miles away from Las Vegas. So the borders between Vegas and Henderson are actually pretty blurred. So this is our main campus. If you notice, a lot of the buildings, unlike the East Coast, are very horizontal. We have land compared to the East Coast. So most of the buildings in Vegas, except the casinos areas, tend to be more horizontal growth. And then we have 3 campuses, 2 in the state of Nevada, and we have 1 campus in South Jordan, Utah. This is our dental school in South Jordan, Utah. And I'm located in Henderson, Nevada. So our College of Dental Medicine, Henderson campus, is in the Las Vegas area. So this is our AGD clinic, and on the other side is the orthodontic clinic. I have a brief video here, but in the interest of time, I'll probably just move on to the actual topic. So that's actually my office right there. So let's jump into the topic of cone beam computed tomography. You know, the age of growth of CBCT happens to coincide with my growth in the US. I've come here about 20 years ago, and I think CBCT has particularly grown in the last 20 years. So in reviewing various concepts of CBCT, I've specifically focused on evidence in the last 10 years with a particular focus of evidence in the last few years. So before we go dig deeper into some of the evidence, let's review some foundational concepts. And as Dr. Ravi very aptly pointed out, for effective diagnosis and treatment planning, a comprehensive evaluation of all necessary diagnostic information is essential. And CBCT is one such diagnostic tool. It is by no means going to reflect upon the overall comprehensive diagnosis, and the use of the validity of any diagnostic tool is dependent upon its accuracy and precision. So CBCT may have all the information in the world that we need, but at the end of the day, due emphasis must be placed on the fact that the clinical evaluation of the patient must be used in conjunction with the radiographic information. And we may not solely depend upon radiographic information. So first, let's review some foundational concepts such as what is accuracy and reliability, right? And again, I understand that several participants are residents as well, so pardon me for some of the seasoned scientists if I'm going into some of the basic concepts. So when we're talking about accuracy and reliability, and for any statisticians or epidemiologists and the participants, please excuse the fact that I have oversimplified the concept. When we're talking about accuracy, what defines accuracy? Who is to say that a diagnostic tool is accurate or not, or reliable or not? So in order to deem something as accurate, we need to have a gold standard. And the gold standard typically is something that's tangible. So for instance, I have a cell phone right here. It's a 3-dimensional object, which I can easily measure the 3 dimensions of the object. Now, if I were to take an image, let's say a CBCT image of the object, any object, but in this case, it's the phone that I'm referring to. And if I'm trying to make sure whether the CBCT capture is accurately representing the dimensions of the object, then I'm able to verify the measurements on the CBCT to the actual object because I'm able to physically measure the object. The same concept is used typically as far as medical research, and especially when it comes to CBCT in the context of orthodontics, to be specific. Our gold standard in this case is typically a dry skull. So it could be a dry skull or a phantom or any object with known dimensions, whether it's volume or linear measurements that's needed to determine whether a tool is accurate or not. So reliability, when it comes to reliability, what does it mean? Synonymously, it's often used in the same context of repeatability and precision. I'm not going to get too technical about this, but let's just use them synonymously. Now with that, in this image on the bottom right, as we can see here, let's say these are multiple texts. Now we see that for any diagnostic test to be considered accurate or as close to accurate as possible, our target is the bullseye. So in this case, we're fairly close, but we don't have the reliability and the precision that we need. Now let's look at another scenario. In this case, We have a fairly good precision, but it's far from the target, which is here. In this case, the test results are all over the place. And many of you may have seen this before, and there's many graphic representations of defining accuracy and reliability. I'm just taking one of the simplest approaches. Now, the bottom right, as you can clearly see, that would be considered an accurate and reliable because all of the results, test results, with repeatability as well, just make sure, yep. With the repetition as well, everything is basically accurate and reliable, all where it needs to be. Now, sensitivity and specificity are other concepts whenever we're assessing diagnostic tools, which we will save for some other time, but it'll come down to the risk versus the benefit and the purpose of the diagnostic tool in determining that threshold of and the margin of error. Now, Cbct, some of you seem to be active users and some may be new users or you refer out. So I'm going to very briefly touch upon the significant advantages and the common concerns. The classic benefit, which we know, is that it's a 3D representation of a 3D object, as opposed to a photograph, which is a 2D representation of a 3D object. So as can be imagined, a lot more information is available in a 3D rendition as opposed to a 2D photograph. So there's no comparison, right? The other thing, given that we have a whole volume, is that it's essentially like a stack of slices of information with the Cbct. And so it allows the end user, depending upon their technical skills and comfort level, to reformat and visualize the focus area in many, many different perspectives and angles, which is an opportunity you would not have with a two-dimensional rendition of any object. And the key benefit would be to the ability to evaluate overlapping anatomical structures, especially with a complex 3D object such as the craniofacial skeleton. Taking a 2D representation versus a 3D volumetric information that you can rotate and revolve and play with it however you want to, the amount of information that you can extract from a Cbct data is just exponential in the right hands. Now, some common concerns as to why it's grown quite a bit, but not probably as much as it should, in my opinion. And the most common concern is cost, especially for a new business owner. And unless it's an institution, understandably, the cost could be prohibitive in the beginning. But like with any technology, just like computers, they were absolutely cost prohibitive, 10, 20, 30 years ago, probably. And now all of us have like 10 different screens. Same thing with any new technology. Over time, the cost does get more affordable. So cost is a very relative concept. And again, with Cbct allowing us to get information from so much, from a comprehensive information of the 3D object, the need to take FMX, bite wings, and any such, even for perio evaluation or any such, you don't need any of that, provided the settings of the Cbct scan are appropriate. So that's a different topic. The next most common concern is radiation exposure. It is upon us as clinicians to be responsible in when and how we radiate the patient, but it's equally important to educate any new users or patients on the true risk versus perceived risks when it comes to radiation exposure. So for instance, if you were to expose a patient to an FMX, bite wings, Anapan, and a Ceph, the cumulative radiation exposure is going to be a lot more significant than one Cbct scan that's taken properly and the cuts are done properly for effective diagnosis. So that's a relative thing as well, depending upon the usage. Now, accountability is a bigger concern that often comes up for advanced users as well, and probably rightfully so, in that we are not necessarily trained to evaluate. As orthodontists, we are not necessarily trained to evaluate and understand the various lesions that may occur in the cranial base or anything beyond the scope of orthodontics and dentofacial orthopedics. But technically, we're acquiring the entire volume of the craniofacial skeleton. So what if a patient has a malignant tumor or any lesion that can grow right behind the superimposed structures that we're not able to see? So that's a common concern as far as potential legality. Now, that's a whole different topic, but there are ways to circumvent that and to address that in the best interest of the patient. At Roseman, we take a Cbct scan as a routine diagnostic record. We are very cautious with the settings that we use, and we mainly use this for pre-treatment and post-treatment. And every single pre-treatment full scan is sent to an oral and maxillofacial radiologist. Any incidental findings that the radiologist finds, we follow through with the appropriate referrals. And in my tenure here, about 12 years now with Roseman University, we have had some very interesting cases where the patient actually came for a routine scan or an orthodontic evaluation only to realize that a life-threatening condition is actually plaguing them. They have been asymptomatic, so they've never known. But when the radiologist alerts us on something like that, we immediately take the necessary steps with the appropriate referral pattern. So there is a cost involved to get every scan read by a radiologist, but that's an evaluation and assessment, the cost-benefit analysis that every provider must make. So before we go deeper into reviewing the evidence of accuracy and reliability studies, I think it's also equally important to understand the importance of acquisition, the data acquisition itself, and what settings must be used. Now, I'm not going to recommend what settings you must use, but I'm going to touch upon the importance of some of the critical components. Now, the top three aspects that I mentioned here, especially the field of view, the voxel size, and the exposure time, are very, very important when you are requesting for, if it's your technician or if you're taking it yourself. The size of the individual may seem like an unusual aspect here that I put it in under acquisition settings, but it does have an impact. An adult versus a child, a large individual versus a small individual. Your field of view would dramatically be different. So you can't just have templated systems that can be used for everyone. It has to be patient specific. And we cannot assume that the technician will take that into account. I think it's our responsibility as clinicians to understand the importance of the field of view and all of the factors that influence the radiation exposure and request the appropriate scan as needed. So what's the field of view? The field of view is the anatomical area that will be irradiated. So in the image below, as you can see, the image on the left would be a small field of view. And you can name it any different way, but essentially I've given three different examples here: a small, a medium, and a large field of view. This would be for the entire craniofacial skeleton. Now, if the purpose is to actually do a thorough assessment of the entire craniofacial skeleton, then you do need a large field of view. But then depending upon the size of the individual, you may have to adjust some other settings. As can be expected, the smaller the field of view, lesser the radiation dosage. But what's the purpose of reducing the field of view if you're not capturing the information that you need? For instance, in this case, I've done my due diligence, kept the field of view small, but I'm only capturing the information of the maxillary teeth, when perhaps I need a little more information, be it depending upon the depth of the maxilla, maybe I need a little more information. If you just say small field of view maxilla, the technician may not be able to do enough justice to the information. Now you may have to re-expose the patient because you did not capture the information that you need. So there is a preview option before taking the scan, which the technicians typically use. But it's a good idea for every end user clinician to keep an eye on those settings if you're owning it. Now let's look at voxel size. What is a voxel? It's similar to a pixel that we talk about in the context of cameras. When we take a picture, the pixels are something that we look into, which impact the resolution. With 3D information, a voxel is basically the smallest 3D element in a 3D volumetric data set. The smaller the voxel size, the better the visualization. So for instance, here, the image on the far left, the voxel size is very, very small. The far right is about 0.4 millimeter versus the far left is about 0.04 millimeters. Now, depending upon the purpose that is sought, this resolution is not sufficient, I would think. Whereas this resolution is great. But if I were to use a 0.04 or anything less than 0.1, let's say, millimeter voxel size, the radiation exposure for the entire craniofacial skeleton would be enormous. And the point is, do we need that level of resolution depending upon what we're looking for? A 0.4 millimeter may be more than sufficient for your initial diagnostic accuracy for orthodontic large skeletal craniofacial structures, if that's what you're assessing. So something to be very closely monitoring as far as the voxel size is concerned. Let's look at another image here. In this case, let's say we're assessing the lower incisor, the bone quality, or the amount of bone height, or the bone height, sorry. Here's another image. The first image on the left is at 0.2 millimeter voxel size. This is at 0.3, and that's at 0.4. Now, depending upon what you're looking for, any of these may work. But if I'm getting as much information as I need to make my clinical decision-making with 0.3 millimeters, should I be exposing the patient to 0.2? No. So that's why it is important for us to evaluate, why am I taking this scan prior to making that recommendation and sending the technician basically a note saying, I need a scan of the anterior area. So you're focusing on the field of view, but you also need to take into account voxel size. Now, the effect of exposure time, that's another critical component. As can be expected, greater the exposure time, the longer you expose the patient to radiation, the greater the radiation exposure. So time is another critical component that needs to be taken into account because it does have an impact on the resolution of the image. Most of these studies are done on dry skulls, like I said, especially when you're looking into accuracy studies. And the exposure time in this study, I have the references at the end for any of you that are interested. I understand the font is small for the references. I have them at later on as well at the end of the presentation. Anyone that has any questions regarding the references, please do feel free to contact me later. The exposure time in this case was modified from 40 seconds to 30 and 7 seconds, as low as 7 seconds. So the image below here goes from 40 to 30 to 7 seconds. The clinician was able to make a clinical judgment as far as implant site is concerned or any other reason why the image is taken equally well with all of these options. So then if I have the option of choosing, I'd go with the 7 second as opposed to 40 second. So in this case, no effect on accuracy and reliability of measurements, linear measurements which were taken, was noted with a dramatic reduction in exposure time. Now, I placed metals and artifacts in this section as well. Movement of the object and its impact on the image quality is not as big of a concern for 3D as compared to 2D, but there is a threshold, like with anything else. Evidence shows that any more than 3 millimeters of patient movement during the acquisition of the data can compromise the accuracy of the information. So stabilizers are typically used to make sure that the patient movement is limited, but CBCT is a lot more forgiving than two-dimensional data captures. Now, when a patient has metal, such as fillings, implants, or let's say they've been through trauma and have some plates in the mandible or anywhere else in the craniofacial skeleton, you may have that information prior to exposing the patient to a CBCT scan. The image here, and that needs to be taken into account in determining what type of scan you will be referring the patient for. So in this image here on the left side, you have a panel with some fillings, small fillings. It does have an impact on the resolution of the neighboring areas, but it does not affect my clinical decision-making. So it may not be as big of a concern. For example, if the objective of this scan is to assess the root parallelism, I'm getting that information. So I'm not worried about the artifact effect. However, let's look at the image on the right with a patient that has a lot more metal. The beam hardening effects will compromise the accuracy, the diagnostic accuracy. The information there is pretty good, but our ability to interpret is compromised with the beam hardening effects. What can we do? Again, it comes down to what do we need the scan for? And then perhaps we can reduce the field of view. Instead of taking a full scan of the entire craniofacial skeleton, we can reduce the field of view. Whenever you can, that could limit the beam hardening effect. So a key point that I'd like to assert here is that the purpose of the CBCT scan must be very clearly weighed to determine the ideal image acquisition settings. A common question that we get is, what is the ideal image acquisition setting? There's no such thing, because it really depends upon the purpose. If I'm looking for some fine detail in one tooth versus the overall craniofacial skeleton, the same settings are not applicable. If I'm looking for this information in a child versus an adult, the same settings will not be applicable. Now, we don't expect every end user to remember the exact numbers as far as the settings are concerned, but being cognizant of the effect of some of these settings would be beneficial in your discussions with the technician. So with that, let's review a few common CBCT focus areas that are helpful in the orthodontic diagnosis and treatment planning. I would like to give a disclaimer here that these lists that I have are not comprehensive by any means. My intent here is to highlight on some common uses of, especially when you are taking a full scan, what can it be used for? And especially areas where accuracy and reliability testing has been done. The actual scope of CBCT is profound. So I'm going to cover as best as I can in the limited time that we have. As far as skeletal components, pathology is of course one of the first things. We need to make sure the patient is disease-free before we can focus on the alignment of the occlusion or any such. So pathology, when it comes to pathology, the need to take multiple scans or images is obviated with a single well-taken CBCT scan. Numerous studies have looked into the accuracy of pathology assessment of various scans. I'm going to generally use pathology here because that's not the purpose of this presentation, or any anomalies. Now, growth and development and developmental staging of the patient is much easier with CBCT. The only caveat, of course, is unless you have multiple scans that are periodically taken, you wouldn't be able to truly assess growth changes. However, based on the information we have from two-dimensional data as well, growth and development studies, the measurements of the various craniofacial structures will allow us to assess the patient's current developmental stage using the CBCT scans. The skeletal relationships, maxilla to mandible, maxilla to cranial base, anything to that effect are much more comprehensive with all of the information that we get from CBCT scan compared to trying to assess that from a PA scan and a CEPH. Those two views by no means are comparable to the amount of information that a 3D can give us. Bone quality and quantity. Now, this is another key thing where to assess bone quality, the acquisition settings, the image acquisition settings must be very clearly thought through because that can impact the resolution, but that's another aspect that we can quickly pick up from the full res as well. For various treatment plans, the TMJ evaluation becomes important. As I pointed out in the beginning, the symptomatic aspects must never be ignored, but in conjunction with the radiographic images, we will be able to better assess the patient. Is CBCT an accurate tool to assess the TMJ? We're going to talk about that in a little bit more. Airway characteristics, especially this day and age with OSA, prevalence increasing. Airway characteristics are critical, especially their relation to the maxillomandibular structures. CBCT allows for us to do that, although caveat there being it's a static image of the airway. Now, as far as dental aspects are concerned, again, a very short list compared to what it can do, but some common things are supernumerary teeth, for example. Unless the patient is symptomatic and unless it's a very clearly, obviously seen supernumerary tooth, it's not easy to pick up on a mesiodens that's beautifully stuck up there on a 2D panel. The localization of that tooth, not just the presence of a supernumerary tooth, the localization can sometimes be very challenging with two-dimensional radiography. Whereas with the CBCT scan, we're able to effectively localize the exact position of a supernumerary tooth, and which will greatly aid in your treatment planning. Because the timing of extraction, should you extract, should you not, there's a lot of aspects that need to be taken into account given the risk versus the benefit. And so that extra information is extremely beneficial. The eruption stage, when we're looking at the amount of bone remaining, that's one of the projects that we're currently working at Roseman with one of my residents. The eruption stage itself, now, which relates to the timing of treatment initiation, whether it is phase 1, phase 2, or comprehensive, the amount of bone left, the alveolar bone left, the bone height, the rate at which the tooth is erupting, these are all things that can be assessed through CBCT. Once again, it does depend upon the resolution that of the initial scan and the ability to do progressive scans, but the clarity and the resolution that you get from a well-taken CBCT to assess eruption staging is very beautiful and effective. Now, tooth positional deviations such as transpositions, another common area where CBCT can be extremely useful to plan whether you're doing the canine substitution or whether you're decide to do an extraction of that tooth. Having a positional orientation of all of the adjacent structures will truly help in your overall treatment plan. The root position, inclination, especially with negative overjet cases, and the image that I showed you earlier at 0.2 versus 0.4 millimeter voxel size, it does make a big difference when you're able to assess the buccal bone height and the bone thickness. That's another thing we'll talk very briefly in a bit. Root resorption is another aspect that a lot of studies have been done with CBCT. Quantifying and localizing, identifying resorption can be challenging unless the appropriate resolution scan is taken. So this is another context where can a full res scan give the information that we need without segmenting the teeth from the 3D volume. Something to think about. Now, localization of impacted teeth. This is probably the most common reason why a clinician would refer out for a CBCT scan. I'm going to talk a little bit more about that. Proximity to adjacent structures. Overall, it's a never-ending list as far as what CBCT can help us as far as orthodontic diagnosis and treatment planning. Just imagine all of this information in one single scan. And that's possible with a well-taken CBCT scan. So let's talk a little bit about some other critical aspects that affect the accuracy of the measurements. Head position and orientation of the CBCT volume is something I'd like to spend a couple of minutes on. So what I mean by this is the position of the object, the person in this case, prior to the scan acquisition and the orientation of the 3D volume after the scan is taken. Those are two different things. So let's look into that a little more. So this is another dry skull study with stainless steel structures embedded in the dry skull to allow for radiopaque objects typically are used to allow for easy identification, especially for accuracy studies on imaging. And it allows the user to, whether it is linear measurements or angular measurements, that can be then compared to the actual physical distances on the dry skull. So in this case, this is prior to the image capture. So in this case, as we can see here, the dry skull has been oriented in multiple different positions, centered versus completely off-centered, versus in this case, the head is tipped up, the pitch effect. And over here, we have a tilt, a significant, I mean, this is very significant tilt, right? So if we were taking a 2D image of such a steep angulated 3D object, a person, the impact on the final image would be extremely significant. However, interestingly, with 3D data, provided there is no movement, significant movement of the person, accuracy and reliability of CBCT measurements were not affected by the significant change in skull orientation. Multiple studies reiterate the same finding. The authors have went as far as stating that the upper lip and chin rests may not be necessary during CBCT image acquisition, since with a head tilt of a significant head tilt may not even impact the accuracy of linear measurements after the scan is taken. However, as I mentioned, movement being an issue, you do want to stabilize the object before taking the scan. But the point here being a significant change in head position prior to scan capture did not have an impact on the accuracy and reliability of CBCT measurements. Now, once the scan is taken, we want to orient the scan correctly before extracting two-dimensional images. Now, why are we extracting two-dimensional images out of three-dimensional information? That is actually just for convenience, because majority of our evidence and diagnosis and treatment planning has been, a lot of the data has been available in 2D world. So until 3D cephalometry becomes more of a reality and common practice, we do rely on two-dimensional renditions of the 3D data. So in order to do so, once the scan is acquired, we are essentially orienting the skull in 3 planes of space: the sagittal, the axial, and the coronal space planes. And the reconstructed cephalograms the two-dimensional cephalograms that have been extracted and built off of this oriented 3D volume has been found to be accurate. So in this case, the head orientation on the CBCT accuracy has been assessed. Now, keep in mind, this is the head orientation after the scan has been captured. The user, the technician, or the clinician must orient the volume prior to extracting 2D information. So in this study, the simulated natural head position versus the 3D reference plane, the most common reference planes used are the transorbital, the Frankfurt horizontal, and the mid-sagittal plane. When simulated NHP versus the 3D reference planes were used, the reliability of the measurements was acceptable. Now, I'd like to impress upon this distinction between the orientation or the head position before the scan versus the orientation after the volume is taken. I've actually played with this scan. This is a patient of mine. To impress upon this point, just a case example here. And I intentionally took a patient that is fairly symmetric and has no pathologies, no major deviations of any sort. Came in for orthodontic treatment for different reasons. So in this case, the red lines, the crossbars, are pointing to the planes that I'm using as references to orient the 3D volume. So the head position earlier, like I was saying, may be taken like this, but when I'm orienting, I'm using my reference planes to orient the 3D volume appropriately. So in this case, the transorbital, the mid-sagittal plane, and the Frankfurt have been used. From that, I built a two-dimensional image, the cephalogram. Now, the diagnostic accuracy of this cephalogram is pretty good. I can easily identify the landmarks, and construct the cephalometric analysis of choice to proceed with the diagnosis and treatment planning. Now, in this image, as you can see, it's very similar to what we just saw earlier. And we have basically the same exact thing that I did earlier, right here. We have the mid-sagittal plane, the Frankfurt horizontal, and the transorbital that I used. I did the same exact thing here as well, with a slight modification. I introduced a two degree tilt in the CBCT orientation. From the first look of it, it looks the same, but if you look closely, there's a little bit of a tilt. Now, when you do the tilt, the roll itself, it can have an impact on the pitch and the yaw. You can adjust for it and the orientation when you're playing with the 3D volume. You can do the manipulation with the single plane or multi-plane. But regardless, when you modify the orientation in one plane, it does automatically have an impact on the other two planes, and you can adjust for that. So in this case, I introduced a 2 degree tilt to the volume orientation. As you can appreciate here, the double border of the mandible is clearly visible. The right versus the left looks different. So let's see what the ceph looks like. I then built on this new orientation with the 2 degree tilt, built the ceph. You can clearly see the double border of the mandible. Significant discrepancy that you can see here between the posterior border of the mandible of the right and the left. And you can also appreciate that with the orbital area as well, the discrepancy in the left versus the right. And that's how I know that this was not oriented properly. Now, keep in mind, this is a perfectly symmetric individual. If this patient actually did have an underlying asymmetry, it can sometimes be very confusing as far as whether it's a true asymmetry or an apparent asymmetry. The best recommendation there would be to reevaluate and make sure that the initial orientation was done correctly, saved properly before building the new 2D X-rays. So the image on the left is with the proper orientation. The image on the right is when I introduce very minor tilt. So essentially, the head orientation after the image is captured can have an impact on the diagnostic accuracy. It will. On all of the two-dimensional information that's being extracted. Now, if you're not extracting the two-dimensional information and you're playing directly with three-dimensional data, then there may not be a problem. But if you're extracting two-dimensional information, and if the orientation is incorrect and not consistent, then your 2D renditions will be compromised. So that's a key aspect to take note of. When you're referring out to an external center that's doing the interpretations and you pick up on something like this, that's an important aspect too. Before you determine that this is a true asymmetry and base your entire diagnosis and treatment plan on it, it is important that we take an extra look and make sure whether it's a true asymmetry or not. Now let's look at TMJ evaluation that we talked about briefly earlier. So this is another dry skull study. So we have here 37 TMJ articulations with the normal lesions, normal condyles, as well as some condyles with lesions. Now, when you are taking a 2D panel, in this case, it's a comparison between a CBCT image versus a 2D. The medial on the lateral side, you can pick up on some radiolucency, but depending upon the location of the osteolytic lesion or any deviations with the TMJ anatomy, you may not be able to pick up on the condylar anatomy, I'm sorry. You may not be able to pick up on some of those issues on the two-dimensional image. Whereas with the CBCT, I'm able to work with the entire data and go through the slices. It's essentially like stacks of information. So I'm going through them in all three planes of space until I find the osteolytic lesion or any other, whether it's an osteophyte or any specific activity that may be present. In our case, every pre-treatment, like I mentioned, we do run it by the oral and maxillofacial radiologist that gives us an assessment of various aspects of the CBCT reading, including the TMJ anatomy in particular, the TMJ complex. There have been times when we picked up on a few things that the radiologist may have missed, and we go back to the radiologist and request for another interpretation. And sure enough, especially because we have the clinical signs and symptoms, the radiologist may not have it. So combining the two impressions is critical to make sure that we have the composite information. So in this study, this CBCT images provided superior reliability and greater accuracy when it comes to TMJ related structural characteristics compared to two-dimensional panoramic radiographs. Now, linear measurements versus volumetric, and that's another important aspect, especially if you're looking for some potential changes as a result of degeneration or any such. CBCT has been found to be a reliable and accurate method for taking volumetric and linear measurements of the mandibular condyles, even in the presence of soft tissue. And it is considered a valid tool for clinical diagnosis. Let's look at two specific measurements. 2D versus 3D panel. When we're working with panos, the focal trough is a common problem that we deal with. We have that same problem when we're constructing a pano off of a 3D information as well, especially if the patient is a high angle patient or has structural anatomical variations of the mandible or adjacent areas. It can have an impact. The width of the mandible, of course, dolichocephalic versus brachycephalic, all of those components will have an impact on how the pano will look like when we're extracting it from the oriented 3D volume. However, the advantage with the CBCT information is that I'm able to manipulate the path and work. When I say manipulate, it's not in a negative way. I'm able to work with the data and move the oriented volume as needed. Look at the cant here. But by the time I adjust for the cant, depending upon the focus area, whether it's the maxillary teeth, the mandibular teeth, or whichever specific area we want to work through, the focal trough issue can be obviated for the most part. So in a study that compared the panos to the CBCT retrieved panos, the tooth lengths were relatively inaccurate with the 2D panos, as can be imagined, especially with the magnification aspect, as well as the foreshortening that can happen. And the only way to adjust is to retake another panel. So going back to the radiation exposure, the cumulative exposure for the retakes that are if we take that into account, a well-taken CBCT, a well-oriented CBCT, and is far less radiation exposure when done right. So in this case, the lengths were overestimated by 2D pans by 29%. That's pretty significant. With CBCT panoramic renditions, they were slightly underestimated by 4%, but that may be considered clinically insignificant. Now, when it comes to linear and angular measurements, especially with reference to teeth, this is actually some of our internal data, a project that we did a few years ago. 15 pre-treatment CBCT scans were taken. Multiple measurements were taken of various teeth, all posterior teeth, posterior versus anterior versus the canine area, and we compared all of them, and it was an interesting study. So what we did in this case is basically the CBCT image and the volume served as its own reference because it's patient data. I'm not dealing with dry skulls here. So when I'm assessing accuracy, what we're looking at is this image right here is from the 2D extracted panel from the CBCT volume. And this is directly from the volume that we're playing with. So the 4-point angular measurements between the teeth have been recorded and compared to the 4-point angle directly on the 3D volume. And we found that the information was, the overall intra and intra-rater reliability was significantly high. The accuracy and reliability in our study clearly showed that the 3D extracted panel, especially when using for root parallelism, was found to be very accurate. Alveolar bone height and thickness, as we talked earlier, especially for class 3 cases, or when you're really in your determination to protract the teeth versus retract them, the amount of bone that you have, that information is sometimes essential because there are some anatomical limits with the cortical plate. So understanding how much bone height we have and bone thickness we have is critical in certain cases. Is CBCT accurate to do so? In this study, 13 dry human skulls were used, 334 teeth were measured, various linear measurements. using a voxel size of 0.38 millimeters at 2 milliamps. The milliamps, that aspect we did not discuss in the acquisition settings. But this would be considered a fairly high, I mean, it's close to 0.4 millimeter voxel, so it's not the smallest size. The alveolar bone height can be measured per these settings to an accuracy of about 0.6 millimeters. Now, when you're dealing with bone height, a tolerance of 0.6 millimeters is not bad. But when you're dealing with bone thickness, that is an issue. And so when it comes to buccal bone height, there was great reliability, but when it came to buccal bone thickness, some concerns were raised. Now, as I mentioned earlier, it does come down to the image resolution. When we're dealing with bone thickness and we're dealing with a millimeter or less, unless the acquisition settings are at a whole different radiation exposure and at the field of view, all of those aspects that we discussed earlier are taken into account, the accuracy of using Cbct, the full scan that's taken for the entire craniofacial skeleton to assess the buccal bone thickness may be challenging. So in this case, you can appreciate that the bone height is more easier to depict versus the bone thickness. Now this is at 0.38 millimeter voxel. By going down the voxel size and by limiting the field of view, perhaps the resolution could be even better. Impacted teeth. As we discussed earlier, localization of impacted teeth is perhaps the most common reason why referrals for a CBCT scan are taken. So I'm going to review a couple of studies. There's many studies that have been done, especially with impacted teeth and canines. I focused in on some of the more recent ones and things that are more relevant to this discussion. So in this study, 118 CBCT scans of patients, a large sample, with at least one impacted canine was used. And as you can see on the top image here, that's from a panel. It's not very easy to localize the position, the true position of these canines and the impact that it may have had on the adjacent teeth. Now you can use the slob rule to take the occlusal, take multiple views. It still is a challenge to truly localize. In other words, we're shooting in the dark sometimes with just an overdependence on 2D images. Now let's look at the three-dimensional data of the same patient. We're able to now localize the canine much more effectively, especially when you have one canine that's going buccal and one canine that's going lingual. The root proximity to the adjacent lateral incisor becomes challenging even with the slob rule and some of the other things that we do. But then again, when assessing root resorption, the acquisition settings, the initial image quality and resolution do become critical. This is another image of a patient with a horizontally impacted canine. That's a PA. Now this is how we're able to review and localize what exactly is happening in that area. Now, perhaps some individuals would say it's a horizontally impacted canine, let's extract it. Not always, but it's all risk versus benefit. However, if I knew that the adjacent lateral as well as the premolar have significant root resorption, even those that would consider an extraction of that canine would perhaps think twice, because now I'm extracting one tooth, the impacted canine that has some good prognosis of coming into the arch, and potentially risking the loss of or premature loss of the lateral and the premolar. So the ability to quantify and have qualitative information of aspects such as root resorption would greatly help us plan our case better. And even if you still choose to bring that canine down, the trajectory as well, you have a better idea of what you're doing with your mechanics if you have a better localization of that canine. So CBCT has been found to be very effective compared to conventional radiographs in evaluating cases, and especially the difficult ones. And those of you that may still be concerned of taking pre-treatment scans on a regular basis, there are certain cases where taking a CBCT scan would truly be in the best interest of the patient. And this would be one of those. Here's another one as far as impacted teeth are concerned. 379 mandibular third molars were examined with a pano and CBCT. Pathology associated with third molars more often observed in a CBCT than in a pano. Let's look at this image. The image on the left is a panoramic image with the third molar encroaching into the space of the second molar, as we can see here. Now, in reality, in the 3D volume, the true distance between the third molar and the second molar may be significantly less, or the third molar probably may not be anywhere close to the second molar. This is the effect of the superimpositions and how the 2D image has been taken. So in this image, when the CBCT was taken, the third molar was abutting the second molar. The overlap was not as significant as it appears here, but there we can appreciate root resorption effect on the second molar. Now you are able to look at the actual sections as well and truly assess the overall impact. Now just imagine the same issue with the second molar instead of the third molar. You probably would think twice before extracting that tooth. With wisdom teeth, we're a lot more generous with extracting them, but perhaps if it's another tooth, this is just an example of any impacted tooth, the ability to localize the adjacent structures with CBCT is significantly superior than a 2D image. So for evaluation of impacted teeth in general, CBCT has been found to be accurate and reliable. So in another study where 29 CBCT scans from another university clinic was conducted. The aim was to localize the impacted canines, and they found that the CBCT was incredibly valuable in localizing the canine as well as in locating resorption. And let's look at this other case. We have an impaction here, the canines and the central incisors. We don't know exactly what's going on with the central incisors. But with the CBCT scan, we're able to slice this into many different sections and observe what exactly is happening to the overall trajectory of the canine in relation to the incisors. There's 20 slices that have been rendered here, and you can start appreciating what is happening to the incisor as you go through each of these slices. You as the operator or the technician can navigate through this. Very brief summary on the effect on skeletal maturity and which is CBN assessment and symmetry in general. Now, when it comes to skeletal asymmetry, as we know, anything more than 5 millimeters is visibly noticeable. But with milder skeletal asymmetries, especially unilateral underlying asymmetries that compound the effect, those are hard to diagnose. Normally, we've used PASFs to assess skeletal asymmetries, but the information available in a PASF is not sufficient to identify some milder asymmetries. CBCT is far more superior in measuring and identifying the true origin of the skeletal asymmetry. In this study, The aim was to validate a method used to assess dental asymmetry in relation to skeletal movement. 10 patient scans were used, small samples, we've reviewed. There are many reasons due to IRB or other reasons, availability of a clean sample. So larger sample is not necessarily always better, but take it with a grain of salt as far as some of these studies with smaller versus larger sample sizes that we come across. And the study reports that the measurements were accurate and mainly reproducible when taken by means of Cbct and with different operators. Same thing with, just to reiterate the point, that's a PSF, cranial asymmetry, and the underlying morphology can be better evaluated with a three-dimensional scan that allows us to actually see where exactly the asymmetry is stemming from. We talked about head orientation after the scan is taken, before building the 2D renditions. This study specifically looked at the impact of that volume orientation effects with the yaw, pitch, and roll errors on the derived lateral ceph, especially when in the context of CVM assessment, the cervical vertebral maturation indexes. 40 Cbct scans and 360 lateral cephs have been used in the study, and they found that the rotational errors led to an overestimation of CVM. So as I showed earlier with one of my patient examples, it's exactly what we're seeing. A cant was introduced in all three planes of space, and the resultant effects, be it CVM, be it cephalometric analysis, be it any craniofacial structures, at the end of the day, the original orientation becomes critical. In other words, that affects, significantly compromises the accuracy and reliability of the subsequent images. Very briefly, as far as airway is concerned, this is a human dry skull study. An acrylic airway model was constructed and attached to the human dry skull in the natural position. Total airway volume was measured manually using the displacement method. The displacement method is a classic method that's used in phantom studies, whether it's liquid displacement or other such, but essentially that's a way to accurately assess the known measurements to what's captured on the image. And that's how we know how close to accurate the measurements in fact are. In this case, the 3D Cbct digital measurements of the airway volume and the most constricted area were both found to be reliable and accurate. A systematic review done not too long ago concerning the upper airway imaging analysis using Cbct indicates that 3D analysis of upper airway can be achieved in an accurate and reliable manner. However, with airway, we do need to be cautious and cognizant of the impact of the respiration phase, the influence of tongue position. Given that airway is a dynamic process, we're capturing, the Cbct is comprehensive, but it's capturing at one point of time. So that does need to be taken into account in evaluating whether it is the minimum constriction area or the volume. Now, 3D cephalometry, I'm going to touch very briefly on this. That's the area that we may be going into. Relatively limited research is available, and this is a growing focus area. Essentially, it automates the cephalometric analysis instead of depending on the operator bias and error in landmark identification and analysis errors as thereby. The 3D cephalometry is an automated process to some extent. In the actual analysis, we're taking the landmarks on the actual 3D volume as opposed to placing landmarks on the 2D extracted images. Automated or not, the fact that we're directly working off of the 3D data makes it user-friendly. However, is it accurate? Based on the current information, 3D cephalometry is not yet an accurate or reproducible diagnostic technique, especially when linear and angular measurements are used. Now, there's more studies coming in this area. However, at the current time, the accuracy is still under question. The definition and identification of landmarks on 3D volumetric images is critical. Structures such as sella turcica were most reliable. However, Porion and Orbitale were inconsistent landmarks, especially with 3D cephalometric studies. This is some data shared by a team of someone that I greatly respect and collaborated with for a few projects, Dr. Karbanda and his team from AIMS. We worked on a couple of projects, and this particular study that they conducted, he's been working, he's done some significant contributions to the 3D cephalometric automation area, especially, as you may know. This study his team evaluated the reliability of landmark identification on these as received CBCT volume versus oriented CBCT volume. As received as in, we took a scan, let's say in this position, and we're starting to use the 3D cephalometric landmarks on that position without orienting it back based on the 3 reference planes that I mentioned earlier. And what they found, and that's what we're seeing here, where the positional errors are not necessarily fixed prior to, because you're not rendering any 2D images from it, there's no need, essentially. So they found that the orientation of the CBCT image does not enhance the precision of landmark plotting if each landmark is defined properly on multiplanar reconstruction slices. In other words, the orientation of the CBCT volume does not gravely impact the ability to identify the landmarks. Now, that is not to say that 3D cephalometry is accurate yet, but this is we're moving in the right direction. They found that midline structures such as Bolton and Nasion were plotted more consistently or precisely when compared to bilateral structures. A lot more research is needed to validate the accuracy of 3D cephalometry. Soft tissue evaluation very briefly. When we're making some treatment planning decisions, whether to extract or not, the effect on profile, the effect on soft tissue thickness, these are some decisions that we need to make. CBCT is typically not routinely used for soft tissue assessments. More research is needed in this area, and some of it depends upon the resolution aspects and the acquisition aspects that we talked earlier. The aim of this study was to evaluate the accuracy of CBCT in measuring soft tissue thickness. Dry skull with wax plates were used of known measurements and thicknesses, and the accuracy of the CBCT in measuring soft tissue thickness was 0.1 millimeters, which is pretty good. Conventional spiral CT is mostly used to determine the facial soft tissue thickness, but that's associated with high radiation dosage, very high radiation dosage. So if the same task can be accomplished with CBCT, that would greatly help in our treatment planning. The aim of this study was to determine the accuracy and reliability of CBCT scans to measure the soft tissue thickness. 7 cadaver heads and 11 soft tissue landmarks were used, and they found that there was no clinically significant difference between the measurements made on CBCT and the actual physical measurements. They even attempted to modify the voxel size to see if that improves or modifies the accuracy. And changing the voxel size did in fact increase the accuracy. And that becomes critical, especially when dealing with thickness and soft tissue. Now keep in mind, when these studies are done on cadavers, the soft tissue presentation would be different from when we're able to conduct some more research on live patient CBCT scans. Another study, once again, looked into soft tissue thickness. 31 landmarks from 20 CBCT scans were taken, and only 5 of the landmarks, they found significant differences in the reported thickness by different observers. In other words, the reliability was somewhat compromised, but only with some of the landmarks. They found that CBCT can be used with good reliability and accuracy. However, further research is definitely needed for accurate evaluation of soft tissue thickness at various junctures of the craniofacial, of the overall facial region using CBCT. Cleft measurements is the last subtopic that I'd like to touch upon. A very important aspect where CBCT can be profoundly beneficial. Now, this image is not part of the study, but for representation of the alveolar cleft and how we can measure it for our benefit in treatment planning, I used this. 12 patients with unilateral cleft were used in the study. The estimated volume of alveolar cleft by preoperative CBCT scans was found to be in this subset of patient pool 1.06 cubic centimeters, the mean. Now the actual bone graft planning that was done, typically the bone graft is planned to be of higher volume, slightly higher volume than the actual size of the cleft. But CBCT was found to be an accurate measurement to calculate the volume of the alveolar defect and the bone graft in alveolar cleft patients. Preoperative scans can definitely aid in quantitatively determining the bone amount needed to adequately fill the bone defect. Another study where 21 non-syndromic uni and bilateral cleft lip patients were reviewed. Average volume of the preoperative alveolar cleft defect was 0.61 cubic centimeter and 0.82 in unilateral and bilateral cleft lip and palate respectively. Volume rendering using CBCT and Amira software is a reproducible and practical method to assess the preoperative cleft volume. To measure some of these, we need the appropriate software. Amira is a tool that I used myself several years ago. Some can be challenging, but what it can do is impressive. So in this case, that's the alveolar cleft. The software allowed for quantification of the area, and it helped in aiding the planning of the bone graft. Now, if we notice, I did not include a lot of information on treatment changes. I limited most of my presentation to aspects that are related to initial diagnosis and treatment planning. I think as far as treatment changes are concerned, changes in bone structure, any such, would be a completely different topic for some other time. But based on the evidence I presented, it clearly indicates that the accuracy and reliability of CBCT data is high with quantitative, especially, but qualitative information as well, especially for craniofacial hard tissues. CBCT derived 2D images are accurate and reliable. The orientation of the 3D volume after acquisition is a critical step prior to extracting 2D images such as cephalograms, panels, or TMJ cuts or such. Training on proper handling of 3D data is essential to prevent improper diagnosis. Most importantly, a good clarity on the purpose of 3D data acquisition is essential for appropriate recommendation when it comes to image acquisition settings, ultimately minimizing the radiation exposure. The LRR principle is something that we always must be mindful of. It's always risk versus benefit that needs to be taken into account. With that, I end my presentation. These are several of the studies that I have used in formulating my own assessments. This is my work family. And this is post-COVID. I guess this is the new world that we live in with all masks. But I thank you, every one of you, for being a part of this session. And I hope some information was valuable for you. And if I missed any critical information of any of the research that any of you conducted, or you'd like to share some additional information to help me advance my knowledge further, please do contact me. This is my email address, pbolu@roseman.edu. Thank you.
Thank you so much, ma'am, for the eye-opening lecture on CBCT in orthodontics for diagnosis and treatment planning. It was a wonderful webinar. Thank you so much again, ma'am. Now I would like to call upon our Vice Principal, Dr. K.T. Magesh, sir, to deliver a few words about the webinar.
Thank you, Dr. Kritika. Distinguished participants, the guest speaker for today. A very good morning to all. I think this is the biggest day in our university for hosting the webinar with participants for more than 36 countries throughout the world, and this is a huge success in itself. It also shows the dedication of the staff members in the Department of Orthodontics under the able leadership of Dr. Deepak for meticulously organizing the today's webinar. Regarding today's program, Dr. Prashanti, it was a wonderful presentation. Two-dimensional radiographs are insufficient, especially in complex cases, and also CBCT images provide better detailed information than conventional 2D radiographs and are user-friendly. And she has proved it again, Dr. Prashanti, that CBCT is one of the most revolutionary innovations in the field of dentistry. Once again, I thank each one of you for your active participation. Hope you all had a wonderful webinar. And I wish soon the pandemic ends and we will resume back to the normal conference and normal seminars soon. Till then, all of you stay safe and stay healthy. Thank you all once again and wish you all a happy 2021. Thank you.
Thank you, VP sir, for your valuable words. We now have the question and answer session on the lecture by our moderators, our Dean sir and our head.
Thank you, Dr. Prashanti. There's one question. Some of the participants wanted to know that you have some third-party softwares which take the CBCT data and they process different information, like for planning for orthodontic surgeries or planning for implants or various other uses in dentistry. So how accurate are these third-party softwares, where they basically not the first-line software of the CBCT machine, which or the software that the company provides? They are basically third-party software which takes information from this and processes that information. So how accurate are they? Are there any studies that says that they are as accurate as the basic software that we have seen in your directly?
That's a great question. To be honest, it'll come down to the actual software itself, and I would have to, conduct a thorough search on that. What we normally do is that we actually analyze the data ourselves, even for orthodontic surgeries, and collaborate with the local surgeons. So when it comes to utilizing other softwares, it really depends upon the user, their training, and the software that's being used. So without the specific name of the software, I think it would be difficult for me to comment on that.
Yeah, so we basically been using a lot, Dolphin, which is supposed to be a pretty good software as far as orthodontic surgeries are concerned. So is there any studies, or have you had any experience using these softwares, using 3D CT data for orthodontic surgeries and for planning complex craniofacial disorders, management of craniofacial disorders as an orthodontist in your university?
Yeah, and that's a good question. We actually use Dolphin and Anatomage, and there are studies on the accuracy of Dolphin as well as Anatomage when it comes to linear measurements and some angular measurements. When we're talking about orthodontic surgery and we're talking about VTO softwares, that would be a whole different realm, and the accuracy has been found to be somewhat compromised for VTOs in particular. So we do not do a lot of VTOs, especially given that the soft tissue, evaluation, which becomes critical when you're discussing with the patient, the soft tissue aspect, as I showed in my presentation too, that's an area that needs more research. So the software aside, the fact that soft tissue thickness evaluation and treatment change effect evaluation projections of what actually will happen to the soft tissue, that still needs to be explored further.
Yeah.
So we do the VTOs mainly for hard tissue structures. We do not incorporate the soft tissue aspect significantly.
I think there's another question by one of our participants. I think she's asked, what is the best software for CBCT segmentation?
We're talking about the different sectioning that I have used, such as the TMJ sectioning. Is that where are we talking about segmentation such as that?
I guess she's
possible. No, if we're talking about segmentation of the volumetric data where we're extracting the entire mandible or the maxilla, that's a whole different discussion. Amira is one of them that I alluded to earlier, and there are many other softwares that are in place as far as extracting, specific components of the craniofacial structure. That segmentation is a whole different ballgame that, unless it's for academic research purposes, we tend not to work on that on a routine basis. However, with all the sectioning that I showed you today was all using Dolphin or an Notch.
I request our Dean, sir, if you'd like to.
Yeah, it was a wonderful presentation, Dr. Prashanti. Just a couple of questions that have come by to me personally. One is how often do you think that you could repeat a CBCT during the process of a treatment? The reason being, though we say we've got a minimal exposure of radiation, how much does the role that you think that we should take off, or do we take a stand on, if we're looking at, let's say, an orthodontic patient, and you're going to rely totally on CBCT, and then how many times would you expose this patient?
Yeah, and that's a great question. I think that's the biggest deliberation that all of us have. There's no easy answer to that, to my knowledge. CBCT has not become a standard of care necessarily for routine radiation for all reasons that you mentioned. What we do is that we do pre-treatment and post-treatment, because otherwise you're not able to realistically evaluate the treatment change. And so we follow the same exact recipe for every single patient, being very cautious with the radiation exposure, given the settings that I mentioned in detail. Now, as far as progress CBCT scans, even with the Alaro principle, as we know, we should base it based on the risk-benefit analysis completely. So the radiation exposure or the fear of or the perception is definitely much more than the reality of it. The newer machines, it really depends upon the machine that you're using as well, which is another aspect that I didn't touch upon, which I will not go into the specific vendors at this time, but generally speaking, the equipment itself, it needs to be calibrated periodically, and certain measures and maintenance have to be done to make sure radiation exposure settings are taken care of. But when it comes to risk versus benefit, I mean, let's think of it from a CT scan versus an MRI. We know that patients, especially undergoing surgery, if we do not have enough diagnostic information from one CT scan, which is well over 1,000 microsieverts, right? We do send them for another CT scan. And if we do not have enough, diagnostic information with contrast or without contrast, we send them for another CT scan, because it'll come down to the risk versus benefit. Now, if the discussion is, should we take a progress full resolution CT scan for our internal understanding of the data, then I would say that's a personal decision that is not in the best interest necessarily of the patient, because it's additional radiation exposure. So I think it'll come down to the risk versus benefit analysis of the individual patient and the clinician's point of view.
Nice. Because why I asked this question was, you see, there was an article from Germany about 4-5 years ago, and they used to do orthopantomographs on a routine basis for when they go in for the dental screening or checkup, annual checkup or biannual checkup. Mm-hmm. And there was a study done that there was a 3% rise or risk of brain tumors on patients who were subjected to routine orthopantomographs. And so, as you said, risk benefit and all these things have to be kept in mind, and depending on what kind of a population we are dealing, or depending upon what situation we do. This is maybe the question that I posed this because I wanted the participants to understand, you just don't keep taking a CT just because you have a facility available with you. And you need to use your clinical acumen at times as well. We are not getting totally guided by an image. Our clinical acumen is also plays a very important role in determining or deciding when to take a scan.
Absolutely. Very, very well said. And I absolutely agree with you. Well, the risk does exist. And I think that's undeniable anytime there's radiation exposure. I think the assessment does come down to risk versus benefit. And the responsibility should be with the clinician. Any tool is only a valuable tool as long as we're cognizant of the purpose.
We have a few more questions. Will there be any changes in CBCT when the patient-centric relation is recorded wrongly?
That's a good point. What we do is we actually take it in centric occlusion to avoid these issues. Now, there are providers that perhaps take them in centric relation, but when due care is taken at the time of image acquisition at centric occlusion, we have never had a problem. And we have taken thousands of CBCT scans. And I also want to add another disclaimer here. And I am by no means advocating for a routine diagnostic CBCT scan to be taken for every patient. That is a position we took here based on, our circumstances and the confidence that we have with the settings that we use. However, it really comes down to the individual practitioner preference and the circumstances therein.
I think there's some questions on the amount of X-ray exposures when using CBCT compared to an OPG regarding localization of impacted teeth. And there's somebody else who also asked about CBCT exposures, among the justification of these exposures. And I actually wanted to compliment you on this one point that you mentioned, that the accuracy of a 2D pano versus a pano from a 3D image. And I did not know till now. I thought a digital pano machine would probably give relatively less distortion. I did not know that a pano from a 3D X-ray or a CBCT would be more accurate than from 2D. So do you think with a pano image being gold standard for evaluating the mouth, you think a CBCT image would be more, valid versus a 2D pano, at least as far as the pano is concerned, considering that the difference in accuracy is so much. So in terms of a patient, if he's looking for a diagnostic method which will give you a more accurate diagnosis, say for example, they're using it for an endodontic purpose. So I think the amount of difference in percentage is so much that would probably make a lot of difference if you're looking at periapical lesion or if you're looking at an endodontic evaluation. So what would be your opinion on that?
Yeah, and the concern as far as radiation exposure, I think it's valid. And that's why I've spent more time focusing on the acquisition settings itself, because that can make or break the whole decision. Now, the orthopantomograph, the regular 2D panel that we take, we do need to be clear about the radiation exposure with that. It's less as long as you're able to get all of the information in one single panel. The reality is, in many cases, clinicians often take a panel and a couple of PAs or an occlusal to get a better evaluation of, especially for a complex case that is involving localization of canines and such. So by the time you add up the cumulative radiation exposure, it can be actually more than one single CBCT scan. So from that point of view, it can be justified. However, if you do not necessarily have access to the machine, or if you're deciding when to refer out, I think as Dean Vivek pointed out earlier, it'll come down to the clinical acumen, the clinical observations, and the need must be, the justification must be made on a case-by-case basis.
Yes.
A lot
Thank
of
you so much.
instances, I do want to add that the actual CBCT scan can be as low as 50 microsieverts, or typically, depending upon your field of view, you're looking at about 100 microsieverts or less. So if you're really taking into account the FMX, the bite wings, and PAs, I think it does add up.
Yes.
But I do not recommend a full CBCT scan periodically.
Yes. What about CBCT scans for pediatric patients? What would be the?
And that's a great point. Now, what we do, it kind of goes back to the field of view aspect. Now, if you accidentally end up basically using the full scan, the most of the current machines, the new machines, they actually give you the option of choosing child versus adult. So that automatically allows you to reduce the overall field of view. However, every child is not the same size, and so is not every adult. So it still needs to be adjusted by the operator as far as the field of view is concerned. So the risk in a growing child, I understand the deliberation and the concern there, but my question will still be, especially for initial diagnosis, if we are just somehow able to justify an FMX and bite wings and a panel and a CEF,
Okay.
I'm not sure if there is a discussion as far as justification for well-adjusted full CBCT scan.
Yes, I understand. I think that's all the questions we have now, and I request our Dean, sir, to kindly give a speaker the certificate, and
Ma'am, just a kind request from our side to enable screen sharing, ma'am.
Oh, I'm so sorry.
Yeah, now it's done. Now it's done.
Now it's done. Now it's done.
Thank you so much, ma'am. Our Dean, Dr. Vivek sir, would now honor the speaker with a certificate of appreciation.
So Dr. Prashanthi, please accept our e-certificate as the best that we could do at this situation. More than that, I think the topic per se was an excellent presentation. And I think a lot of students and residents would have definitely largely benefited out of your experience. And once again, I really appreciate that you've taken your time off, and you're probably in a very odd hour right now, wherever you are talking to all of us. So appreciate that, and thank you once again.
Pleasure is mine. I greatly appreciate this opportunity. Thank you.
Thank you, madam. Thank you again.
Thank you, ma'am. Thank you, sir. Participants are requested to fill the feedback forms, the link for which is provided in the chat box. You'll receive your certificates once you submit the feedback forms. Thanksgiving forms an integral part for the success of any program. So I would now like to invite Dr. Akshay sir, senior lecturer from our department, to deliver the vote of thanks.
Thank you, Dr. Kritika. I now take this privilege to propose the vote of thanks on behalf of the Department of Orthodontics and Dentofacial Orthopedics from SRM Katangalatu Dental College. Gratitude is one of the least articulate of the emotions, especially when it is deep. So a heartfelt thanks to each and every one of you present today for taking time from your respective schedules to grace this occasion. Firstly, I would like to thank God Almighty for giving us this day to conduct this webinar. I would like to thank SRM Institute of Science and Technology for giving us this opportunity to conduct this successful webinar today. A grateful thanks to our beloved Dean Sir, Professor Dr. N. Vivek, for his support and guidance for organizing this event and for enlightening us with your inspiring and motivating words. Thank you, sir. It gives me immense pleasure to thank our Vice Principal, Professor Dr. K.T. Magesh, for being a strong pillar of support and supporting us throughout this endeavor. Thank you, sir. I would like to thank Dean SRM Ramapuram Dental College, Professor Dr. Ravi sir, for his cooperation and involvement in his organization of the event. Thank you, sir. I extend my sincere thanks to our stupendous speaker who has enlightened and shared her knowledge with all of us today, Dr. Prashanti ma'am. I'm sure after today's webinar, most of us are well motivated and will take a step forward towards using CBCT for diagnosis and treatment planning. From the core of my heart, I would like to thank our head of department, Professor Dr. C. Deepak, who has always encouraged us in all our endeavors and has always driven us towards expanding our knowledge. I would like to thank the departmental team, Dr. Divya, Dr. Deen Dayalan, Dr. Nidhi, Dr. Kritika, Dr. Praveen, and Dr. Manushri for all their support and guidance, without whom this webinar won't be possible. And a special thanks to my dear postgraduates for all their help and being there whenever needed. I would like to thank the technical team of SRMIST who have extended their full support in connecting all of us through various modes and for making this webinar a grand success. Finally, we all once again thank one and all from the core of our hearts for making this program a success by your presence. Thank you one and all. Have a good day and a very happy new year. Thank you.
Thank you so much. Thank you again, Dr. Prashanti, for a wonderful lecture.
Thank you. Okay, so it's about 11:30 a.m. for you guys, right? It's about 10 p.m. here in Vegas. So
yes, okay, bye. Thank you so much again.
thank you, everyone.
Bye.
Request the participants again to fill the feedback forms. It will be open for only a few minutes from now. Once you fill the feedback forms, you'll have to submit it so that you'll receive your certificates in your mail. Thank you.
You have to fill up one form. Even I am filling up. Then only